Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Today we're going to be talking about the very important topic of peak and plateau pressures. These are two pressures that we can get on the ventilator that give us access to some of the patient's physiology. They're very important. It's something we talk about pretty much every day for patients on mechanical ventilation. In this lecture, we're going to talk about what these two pressures are. We're going to talk about them in relation to the physiology they're representing. We'll talk about what's normal and what's abnormal, and then we're going to go into the causes of abnormal peak and plateau pressures. Last, we'll talk about what this looks like on a pressure scaler, and then I think we'll wrap up after that. So as a friendly reminder, we at Whiteboard Medicine, this is our homepage on YouTube, have had a number of great videos that we have put out on mechanical ventilation. So if you scroll down to medical education, you click on the pulmonology playlist, you can see here, and we'll link all these in this video's description. You can see lots of previous videos on mechanical ventilation. So this is a topic you're interested in, you're trying to learn about. Certainly we encourage you to check out these other videos. Hopefully they'll be helpful for you. No further ado, quick 30-second break for introduction. Don't go anywhere, we'll dive right in. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So peak and plateau pressures. These are two separate pressures that the ventilator measures. And the reason they're separate is because they represent different physiologic findings, right? The measurement they are taking represents two distinctly separate things. The nice thing about peak and plateau pressures is it can give us a clue into the patient's physiology. In addition to that, we need to manage these pressures. We don't want them to go too high because they can cause damage. Things like barotrauma, where the lung gets too distended, the alveoli get too distended, and as such they get damage. But to further understand some of these concepts, it really is helpful to dive into what these pressures are representing. So if we scroll down, we drew a quick and dirty version of the lungs, right? Right side, left side. This is the trachea, the main stem bronchi, and all these bronchi obviously break up into smaller and smaller bronchi into bronchioles, and eventually if you were to zoom, way in, this would end in kind of these balloon-shaped alveoli, right? And these are kind of balloon-shaped alveoli. That's a really terrible drawing. Let's try it again. Terminal alveoli, and these are the little balloons that actually inflate and deflate for gas exchange. This blue thing here is an endotracheal tube, right? There's a plastic tube that goes into the trachea. You blow up a balloon here so it forms a seal, right? And the ventilator delivers a breath into the endotracheal tube, right? That breath comes out of the end into the trachea. It goes into both bronchi, and then it waves its way into all the bronchi and bronchioles into the alveoli, and then it inflates the alveoli, and expands the lung, right? So this lung expands out. After the breath is stopped on the ventilator, right, the lung then contracts back in, and the air goes the opposite way. So it travels back out the main stem bronchi into the trachea, into the endotracheal tube, and then out the endotracheal tube towards the ventilator. Right? That's just the basics of how a breath is delivered on mechanical ventilation. So when we're evaluating a patient on the ventilator, let's just say you're prepping for rounds in the morning to present the patient to the attending intensivist, there's two pressures that we're interested in, right? The first is the peak pressure, and the second is the plateau pressure. And these are both pressures that you can get off the ventilator. The peak pressure is often in the top right corner. It depends on the ventilator brand, but the top right corner. And it's a pressure that you get with every single breath. Whereas the plateau pressure is something you actually have to test for. You have to do this inspiratory hold maneuver that we'll talk more about to get the plateau pressure. So what are these? Starting with the peak pressure is the pressure the ventilator is experiencing when it tries to push a breath into the lungs. So ponder that for a second, right? This is a closed circuit, right? This endotracheal tube ends up coming out of the patient's mouth, and then there's kind of tubing that weaves away onto the ventilator itself. But this is a closed circuit. It's not open to the external environment, right? From the tubing to the endotracheal tube. There's this balloon that causes a seal into the lungs. So when this ventilator delivers a breath, the breath travels through the tubing, through the endotracheal tube, through the bronchi, and into the lung tissue. And the pressure that is required to flow that breath through the tubing, the endotracheal tube, these airways, and inflate the lung is the peak pressure. And that's why you get it with every single breath. Because when the ventilator pushes that breath in, it says, oh, this is the peak pressure that I experienced while I was trying to inflate the lungs on that breath. So if we think about what that means is it's really a manifestation of the airway resistance and the alveolar resistance, because those are the two things that are happening. The breath is traveling through the airways, and then it's inflating the alveoli. So the resistance of those airways and the resistance of those alveoli are what is going to create the pressure that ventilator experiences while it's trying to deliver a breath. Right? If we just make this more simplistic, let's just picture you had a pump, right? Here's your pump. It's got a little nozzle at the end, and that nozzle is kind of plugged in to a pipe, right? And then there's a balloon on the end of that pipe. The peak pressure would be the pressure it takes you to pump a breath through this pipe into the balloon and then start to inflate the balloon. Right? If you're blowing into that, the amount of force you have to push in, the pressure required to flow the air through that pipe and inflate the balloon is the peak pressure. And that is why it's a manifestation of the resistance of those airways to the breath flowing through them, as well as the alveoli resistance as they try to inflate. So really the peak pressure is airway and alveoli resistance, okay? Now, as we talked about, it's detected when the breath is being delivered, right? Because it's an airway resistance. As the breath is flowing through these airways, that is when it detects the peak pressure. And do note that this is all in volume control. This is more of kind of an advanced topic and probably outside the scope of this video. But there's different modes of mechanical ventilation. There's volume control, there's pressure control, there's SIMV, there's APRV. There's all these different types of mechanical ventilation where you can deliver breaths differently. And peak pressure is really a discussion in this context for volume control, which is the most common modality of mechanical ventilation. Okay, and the acceptable norm, I put acceptable in quotes here because acceptable is not necessarily normal. Acceptable is what we tolerate without getting very concerned and having to adjust the ventilator settings. And the acceptable peak pressure is less than 40 centimeters of water. So when you look at the ventilator and you get this reading, the peak pressure, you're going to get a reading that says X centimeters of water, right? Maybe it says 33 on that breath, 32 on the next breath, 34 on that breath. And these are all pressure measurements, right, in centimeters of water. This is in contrast to the plateau pressure. The plateau pressure is detected with what we call an inspiratory hold maneuver. So essentially what we're doing is we are pushing a breath in, and then we are pausing the ventilator. We're not letting any air out of the ventilator, and we're not letting any more air go back into the lungs. So I'm going to erase all this, and we can see if we can kind of draw it. I'm going to redraw, right? The endotracheal tube comes out the mouth. There's this tubing, right out the mouth. There's this tubing, and it goes onto the ventilator. And again, this is a closed circuit. The idea that it's a closed circuit is really important. So when we deliver a breath in, as we said, the breath travels through the tubing, through the endotracheal tube, through the trachea, the bronchi, into the bronchioles, and then it inflates the lungs, right? It goes to both sides, obviously. The plateau pressure is the pressure experienced when this breath is pushed in, but not let back out, and you pause the flow on the ventilator. There's no air flowing in or out, right? So just picture it. It's essentially if you took your own breath in, and then you just held it in your lungs. You're not letting any air in, you're not letting any air out. You can almost feel the pressure in your chest when you do that, right? Because your lungs are inflated, and your lungs are tissue. So as the air is pushing those lungs out, the lungs are also pushing back in. They're trying to deflate back down. And if you're not letting any of that air escape, the plateau pressure is the pressure that the vent is feeling as those lungs try to deflate when we won't let them. It's an inspiratory hold. So as one might assume then, that plateau pressure is more representative of the lung compliance. The compliance being how easy those airways are to kind of distend out and collapse back in. You can also think of it as kind of an alveolar resistance and lung compliance measurement. So if we think about what this is saying, the plateau pressure is actually sort of a part of the peak pressure, right? Because as we said, the peak pressure is when we push an air in, and part of the peak pressure is airway resistance, but the other part of the peak pressure is we have to inflate those lungs, right? And if we're saying plateau pressure is lung compliance, the force that the lungs are trying to push back in on that breath, you can think of the peak pressure as airway resistance plus lung compliance plus the plateau pressure. The physiology there isn't perfect, but it's somewhat helpful in understanding these two things. Because when we think about peak and plateau pressure, we're going to talk about kind of highs and normals. An acceptable plateau pressure is less than 30, right? And that's acceptable again, because that's not necessarily normal. If you put a healthy person on a ventilator, their peak and plateau pressure would be very low, right? So this is acceptable. This is what we think is okay and will not induce a significant amount of barotrauma or overinflation or overdistension of those alveoli. So the difference between these two, the peak and plateau pressure, is important. Because if they are the same, right, if the peak equals the plateau pressure, let's say the peak pressure is about 30 and then you do this inspiratory hold and the plateau pressure on the inspiratory hold is also 30. That is really saying that most of the pressure that you're seeing in the peak pressure is simply lung compliance and that there's not much airway resistance because lung compliance and airway resistance make up the peak pressure. Right? Does that make sense? So if the peak pressure is proportional to airway resistance, right, we'll just say airway R, and lung compliance, lung C, and we're saying the plateau pressure is proportional to lung compliance, if the peak equals the plat, that just means that all the peak pressure is lung compliance and the airway resistance is not contributing. That's in contrast to if the peak pressure is greater than the plateau pressure. So let's just say the peak pressure is 50 and the plateau pressure is 20. Well, now this changes, right? Because if we're saying the plateau pressure is 20 and the peak is 50, we can essentially say that, well, 20 is related to lung compliance, but the other 30 left is airway resistance. And this can be helpful when understanding the pathophysiology going on because these two represent different things. So anytime the peak pressure is high, the second question is, what's the plateau pressure? And if the plateau pressure equals the peak pressure, this is really a lung compliance problem. If the peak pressure is greater than the plateau pressure, it's really an airway resistance problem. And both could be high, and it could be a both problem as well. But the differentiation between the two is important in deciding if it's an airway resistance problem or a lung compliance problem. Because airway resistance and lung compliance are going to represent different things, right? So as we mentioned, let's say there's a high peak pressure and a high plateau pressure, right? So peak pressure is 30, let's make it 50, plateau pressure is 50, that's very high. Well, remember what we said. If the peak and plateau equal each other, this is really just a lung compliance problem. Because the plateau pressure is lung compliance. And if the plateau equals the peak, that means airway resistance is not playing a big role because we said peak pressure is airway resistance and lung compliance. So if they equal one another and plateau pressure is just lung compliance, again, means airway resistance isn't playing a role. So then we think about the things that cause an abnormal lung compliance. And that is the pathophysiology that's leading to that high peak and high plateau pressure, abnormalities in lung compliance. And those abnormalities, the easy way to think about it is kind of blood, water, pus, inflammation, fibrosis, right? Blood being things like hemoptysis. If you have blood within the lung parenchyma itself, hemoptysis isn't the disease, but it can be caused by a number of things, right? DAH. It can be from any type of arterial bleeding in the lung, right? So blood in the lung can cause abnormal lung compliance, right? Because that blood gets in all those alveoli, clogs them up, doesn't allow them to distend as they would normally, right? Water, so things like pulmonary edema, P edema, can cause an abnormal lung compliance. Pus being infection, so things like pneumonia. All right, inflammation can be from anything. Let's say you have pneumonitis from maybe you aspirate and you have aspiration pneumonitis. Maybe you're on some type of chemotherapy agent that causes medication-induced pneumonitis. So any inflammation in the lung. And then fibrosis, right? Fibrosis can cause the lungs to have decreased lung compliance. Maybe it's like interstitial lung disease causing fibrosis. So if you remember these, that gets you through most of the things that can cause an abnormal lung compliance. The other thing is if you're not ventilating all the lung like you think you are, right? So if you intubate someone and you accidentally mainstem them, right? Meaning the endotracheal tube is actually going into just one of the main stems. That means you're not really ventilating this lung. So you're trying to push all the tidal volume into a single lung, and that will lead to a high plateau pressure because that lung is exerting that much more downward pressure as it is trying to accept that full tidal volume. Similarly, if you had lung collapse of a certain area of lung, that would cause higher plateau pressure as well because you're ventilating less lung than you think you are. Or if you had a pneumothorax, a popped lung, let's say this lung's totally collapsed because there's a pneumothorax. Again, you're just ventilating one lung. And the amount of tidal volume is the amount of tidal volume, right? Let's say you set the tidal volume at 500. That tidal volume is supposed to go into both of the lungs, right? And if it's only going into one of the lungs, so instead of getting 250 and 250, this lung's got a pneumothorax and is collapsed down. That means now you're trying to put 500 cc's of tidal volume in that one lung, and you're going to over-distend it. You can think of it like a balloon again, right? If you're pushing 250 cc's into a balloon and then try to push 500, that pressure, that compliance that it's coming back down with is going to be more robust. Okay, so if you're not ventilating both lungs the way you think you are, whether you mainstem the intubation or have a pneumothorax or have some degree of collapse, then otherwise this blood, water, pus, inflammation, fibrosis are the things that can cause abnormal lung compliance, which is the high peak and high plateau pressure. And this is just to echo, right? Because the peak pressure of some of the ventilator just tells you on each breath. So if that peak pressure is high, the second question is always, what's the plateau pressure? So do that inspiratory hold. It's a button on a ventilator. You hold the button and it pushes a breath in and then it holds it and it tells you what the plateau pressure is. Because the plateau pressure equals the peak pressure, then you know it's a lung compliance problem. Whereas if the plateau pressure is normal, it's low, so it does not equal the peak pressure, cue this other one, we know it's an airway resistance problem. I feel like I'm repeating myself over and over, but this is just to really drive home the point, right? Peak pressure is both airway resistance and lung compliance. Because the peak pressure is the pressure the ventilator is experiencing when it's pushing a breath in through the airways and inflating the lungs. Whereas the plateau pressure is just a lung compliance problem because the plateau pressure is when the ventilator pushes a breath in and then holds it, doesn't let any gas flow back and forth, right? And then that is just a representation of the lung compliance. So if it's a high peak pressure to normal plateau pressure, you already know the lung compliance is normal, right? So you're taking this out of the peak pressure equation, so you know all that's left is airway resistance, so you have an airway resistance problem. And anytime you have an airway resistance problem, what you want to do is you want to trace the circuit, I call it. Because remember what we said? We said you have a ventilator, and you have ventilator tubing. And that tubing then attaches to the endotracheal tube, right? And that endotracheal tube is going into the lungs, into the trachea. The endotracheal tube's got a balloon here and a balloon here, and it is creating a closed circuit for your lungs. So if you have airway resistance, that does not just mean airway. That could be resistance in the endotracheal tube. It could be resistance in the tubing. So the first thing you always think about is endotracheal tube pathology. Is there a kink in the tubing? Is the patient biting the tubing, making it more small? Is the endotracheal tube too small to start with? Is there mucus built up, right? Because all those things are going to increase airway resistance. I'm just going to draw an endotracheal tube, right? If you're trying to flow air through this endotracheal tube, and let's say there's mucus built up on the side, you got a big goomba right there. Now that air's trying to flow by a smaller area, and that's going to lead to more resistance. Or let's say the patient's kind of biting down on the endotracheal tube. So instead of this nice flat surface, you have this huge kink in the side because the patient's biting down on it. Again, you're going to have to try to flow that air past a smaller surface, and that's going to cause higher airway resistance, a higher peak pressure. So the first thing to do is to trace the circuit, trace the endotracheal tube. If the circuit and the endotracheal tube are all okay, well then you actually are having a true airway problem. And just like the endotracheal tube pathology, the problem with the airways could be mucus plugging, right? You could have mucus built up in one of the airways, just like you could in the endotracheal tube. And now you're trying to push air past mucus built up in the airway, smaller area to push it through, higher airway resistance. You also could have bronchospasming of the airways itself. Maybe the patient has COPD or they have asthma, right? And those bronchospasms is when those bronchi kind of spasm down, right? Creates smaller amount of area to flow that air through, higher airway resistance. Maybe there's a foreign body in the area. Maybe the patient has ventilator desynchrony. They're not being cooperative with that breath and they're kind of pushing back on it. All those things can cause high airway resistance. So again, high peak pressure. Second question is, what is their plateau? If it's a normal plateau pressure, then you know the lung compliance is normal and you have an airway resistance problem. If it's a high peak pressure and a high plateau pressure, then you know it's a lung compliance problem and not an airway resistance problem, right? And that similarity between the two is if they're within about 5 centimeters of water. Now, if they are both high, right, let's say the peak pressure is 60 and the plateau pressure is 40, they're still different enough where you have an airway resistance problem, but you also have a lung compliance problem because they're both high, right? We said a acceptable plateau pressure is less than 30, and we said an acceptable peak pressure is less than 40. So they're both high, but the peak is higher than the plateau. So we know that you have both a lung compliance problem and an airway resistance problem. All right? So if you think about it that way, it sticks a little bit better, I think. And then last but not least is just the scalars. If you don't have an interest in this or don't have the background, this certainly isn't that important. But this is a pressure versus time scalar. This is something that shows up on the front of the ventilator screen. And remember, this is in volume control. And you can see here that this is 0 for the pressure. The peak pressure is going to be the peak pressure that the ventilator experiences when it's pushing a breath in, right? So this is where it's starting to push a breath in, and then it gets to this peak. And this is what the ventilator is putting on the side of it, right? This is 30, the peak pressure is 30. The plateau pressure, though, as we said, is a maneuver you have to do. So I wonder if I take a marker, I'm just going to draw over this so we can draw something fresh. Just pretend like it's the same color as the other ones. So if you do an inspiratory hold, right, a patient takes a breath, they have the peak pressure, and then you have an inspiratory hold, the ventilator will go like this. This is when it's holding the breath. And then you let go, goes back down to 0, and the patient can take their normal breath again. Okay? This here is the plateau pressure, right? This portion of the inspiratory hold. So that is literally on the scalar will give you a pressure. You know, if this is 30, let's say maybe this is just 20. Nice normal plateau pressure. And it will kick this out on the screen too. There will be a little area that says plat, and then it'll give you a number like 20. But you have to do the inspiratory hold, right? You have to hit the button. And our respiratory therapist will do this. Certainly shouldn't be doing it too much on the ventilator without the respiratory therapist, especially if you're early on in your training. But you have to do an inspiratory hold to get the plateau pressure, whereas the peak pressure is just that peak pressure at the end of each breath, and that's an automatic thing the ventilator reads. So hopefully that was helpful or interesting, or at least stimulated some additional reading. Let us know what thoughts, comments, questions you have down below. Definitely check out our Patreon page, our other related videos, and certainly we appreciate you checking it out. In any case, stay well, keep learning. We'll see you next time.